First of all, I want to thank the organizing committee for this kindly invitation. And my talk is it's about EVAR versus open repair. Where are we? I'm just presenting to you an observational and retrospective study of a personal series of 122 AAA treated by EVAR. The mean follow-up was 5 years. There was one surgical conversion related to renal artery coverage, 4 preoperative deaths, including one related with AAA, 1 endoleak type A, 1A, 3 endoleaks type 1B, 11 endoleaks type 2, and during the follow-up there were 4 deaths, including 3 unrelated with AAA. When you have a complex AAA like this, how to treat it? By open or by EVAR? The improvement of the material makes that endovascular treatment of infrarenal AAA is currently routinely performed in patients with favorable anatomy. A lot of randomized studies have demonstrated low perioperative morbidity and low mortality after EVAR compared to open surgery in short and mid-term follow-up. EVAR is performed even in young patients and in those who did not have risk factors and who could have been treated by open surgery. But long-term follow-up poses the problem of the durability and the cost of EVAR. Endovascular treatment allows exclusion of the aneurysm, but the aneurysmal sac with its thrombus will remain and will cause a new disease that will be monitored regularly. Currently, the anchoring of the new endografts is stable, but remains the problems of underleaks and the tension and leg enlargement. Open surgery by flattening grafts suppresses the aneurysm and allows a definitive recovery in more than 90% of patients. The follow-up is simple and inexpensive. EVAR is indicated in case of suitable anatomy, anatomy of the neck and anatomy of the iliofemoral axis. EVAR requires long-term monitoring. Here are the ESC guidelines published in 2014. If a large aneurysm is anatomically suitable for EVAR, either open or endovascular aortic repair is recommended. If a large aneurysm is anatomically unsuitable for EVAR, open aortic repair is recommended. And in case of symptomatic AAA, anatomically suitable for EVAR, either open or endovascular aortic repair is recommended. As this recommendation recurrent, there is complications in open surgery, but there is a very low mortality in centers that practice many such interventions with experienced surgeons. And EVAR is currently performed totally in percutaneous, but there are possibility of intraoperative complications as surgical conversion related to failure of stent expansion, renal artery coverage, or endograft malposition, and also late complications, mostly aneurysm rupture, most often contemporary with an endoleak. There are operative advantages of EVAR compared to open surgery. The mean duration of the procedure is shorter. There are less blood loss, less transfusion, shorter hospital stay, and shorter ICU stay. And there are also disadvantages of EVAR, radiation, injection of contracts, but mostly the total cost of EVAR that there is very high. Lovegrove in 2008 reported a compilation of 42 randomized studies, and he reported better results in short term and mid-term in the EVAR group. And Goodney also reported the same results, and Saradzit in 2014, reported the same results, better results in short term and in mid-term follow-up in favor of EVAR. And he claimed that there was more deterioration of renal function after open surgery than after EVAR with suprarenal fixation. So, the initial results of endovascular treatment led to euphoria about this procedure, but the recently published long-term results tempered this keen interest. In EVAR 1, DREAM, and OVER, there was better outcome in short and mid-term follow-up. But in EVAR 1 at 8 years, the aneurysm-related survival rate was at 93% in both groups, but with a higher complication and secondary intervention. In DREAM, also the same result, and OVER, also the same result. So there is many intervention in EVAR compared to open re-intervention in EVAR compared to open surgery, which decreases the long-term benefits of this endovascular approach. Endoleaks are the main cause of EVAR intervention, and up to 70% of endoleak reintervention are caused by type 2 endoleak. In 2018, Patel reported an article about EVAR1, and he said that the increased aneurysm-related mortality in the EVAR group after 8 years follow-up was mainly attributable to secondary aneurysm sac rupture, and he concluded that EVAR has an early survival benefit but an inferior large survival benefit compared with open repair, which needs to be addressed by lifelong surveillance of EVAR and reintervention if necessary. In EVAR trial 2, comparing a group of patients treated by EVAR and another by medical treatment, all the patients were ineligible to open surgery. It reported that the rate of complication related to the stent and the operation were higher in case of EVAR and therefore higher cost, and that there was a comparable all-cause mortality rate in both groups. And surprising, this presentation of Stenson in the last June in the British Society of Endovascular Therapies. She reported a prospective study of 86 AAA treated by EVAR, and she claimed that after 9-year follow-up there was no secondary ruptures, and that the cost was effectiveness and the patient safety. But the cost of EVAR is high. In EVAR DREAM and OVER trial, agree that the burden of reinterventions over 14 years is much higher in the EVAR group. The cost is higher, and this high group is related to the follow-up with imaging and secondary intervention. Besides the group, the cost, there are also the question of the durability. In EVAR 1, DREAM, and OVER, the two trials used old ondografts, and they shown that over 14, 15 years of follow-up, there was no difference in survival between EVAR and open surgery, and that there was an increased number of reinterventions in the endovascular group. There is question about durability. Indeed, studies shown an enlargement of the aneurysm sac of more than 5 mm in 5 years in 41% of cases, and complications rise from the 4th year, and the annual risk of rupture on endograft is ranging from 0.5 to 1.2%. So questions must have answers: how to ensure the durability of the new generation of endografts, how to ensure the cost-effectiveness of endovascular treatment, and how to improve outcomes of EVAR. Are the new devices, the new endografts, can help to answer these questions? New devices to treat hostile necks, outside shimland sandwich technique as endurant ovation, leaks, and also stapling the aortic securement system. Endurant is a stent graft with M-shaped sealing proximal stent and suprarenal bar stent which anchor. The ENGAGE registry, after a 5-year follow-up, reported that ENGAGE demonstrated sustained safety, effectiveness, and durability. The ovation is a 3-modular device with suprarenal fixation. The sealing mechanism which is accomplished by a pair of compliant inflatable rings that are filled with a low viscosity radio-opaque polymer. A retrospective study of a series of 74 patients reported 0% endoleak, type 1A and 3 at 5 years. And the NELIC system is a device comprises 2 stent grafts with double balloon, each surrounded by a polymer filled endobag, allowed anatomical fixation in the aneurysmal sac, and effective sealing at the proximal neck. The endobag feed the aneurysm sac, obstructing the side branches, avoiding endoleak type 2. But the long-term results are not yet accurate, and CE mark suspended for this device. In conclusion, in recent years, it is considered that endovascular treatment of AAA is a treatment of choice, whatever the age or risk of the patient, except in cases of adverse anatomy. The prognosis of EVAR procedure is highly dependent on AAA anatomy, material quality, procedure planning, team training, and operative experience. But surveillance of patients after EVAR is stringent and expensive. However, it is mandatory because it can detect complications that will be treated in time, allowing the reduction of aneurysm-related deaths. In addition, the considerable development of EVAR has led to a lack of training of young surgeons in open surgery, and therefore to the sometimes complex surgery of reinterventions. For all these reasons, it would not be surprising to go to the recommendation to restrict EVAR indication and expand those of open surgery to more patients with long life expectancy who fully adhere to proposed treatment. But currently, in any case, the AAA therapeutic techniques remain complementary. Thank you for your attention.